can't start women on hormones postmenopausal. It's not safe.
Hormone replacement therapy is going to be ramping up probably quite a bit in the next few years, and we want people to know how to do it.
Millions of women just being inadequately undertreated in the US and in the whole world.
With the dried urine test, you're able to look at a urinary level of estradiol and say, I know that I'm getting into the clinical range that's protecting the bones.
There's a revolution happening, I think, in women's health.
Hi, listeners. It's hard to believe, but New Frontiers in Functional Medicine has been going strong since 2015. With over 200 episodes and over 2 million listens, we are growing every year. My goal is to continue to bring you the best minds in functional medicine, epigenetics, and longevity. I want the content to be actionable for the functional medicine clinician and interesting for the rest of us. Thank you for supporting this podcast with your likes, with your honest reviews, with sharing the episodes with your friends and family. And if you haven't done so, please consider leaving a like or leaving us an honest review wherever you've accessed this podcast. Thank you, thank you, thank you to our sponsors. These are companies that I trust, that we vet carefully, that we use in clinical practice, that I use personally. Because of them, everything associated with this podcast is free. If you haven't done so, I suggest you head over to drkarafitzgerald.com to the podcast page where you can access the full transcript for every single one of these 200 episodes. And along with that transcript, you'll get an episode summary. You can get the research citations and additional content that is pertinent to the episode. Or better yet, sign up for our newsletter, again, at drkarafitzgerald.com, and every single podcast episode will drop in your email as soon as it's released. Thanks again.
Hi, everybody. Welcome to New Frontiers in Functional Medicine, where we are interviewing the best minds in functional medicine. And, of course, today is no exception. I am thrilled to be talking to Dr. Allison Smith about all things hormones and hormone testing. Let me give you her background and an incredible promo from Precision Analytical, and then we're going to dive into this cool podcast. Dr. Allison Smith completed her ND at National University of Natural Medicine in Portland, Oregon. She has worked in private practice, focusing on primary care, women's health, and dermatologic laser therapy. Over the last 10 years, she's consulted with providers on thousands of cases in the context of hormone testing and brought awareness of testing to providers in clinical practice through consultations, webinars, case presentations, and articles. She now leads a large and esteemed group of clinical colleagues at Precision Analytical, home of the very famous Dutch test. And if you haven't done the Dutch test, or you're a regular Dutch user, as we are in my practice, they have an amazing team to consult with. We use them routinely. So even though I've been doing the test for years, I just pinged you guys the other day, in fact. But here's some training that they're offering. I just want to make you aware of it. Go to dutchtest.com and register to become a provider in order to access Dutch Test's upcoming hormone replacement therapy course. This will be extraordinary, underline extraordinary a couple of times, because they have such a strong clinical team. You don't want to miss this opportunity to level up your knowledge and bring more clarity to your practice. Dr. Smith, welcome to New Frontiers.
Thank you so much for having me on. I'm so excited to talk to you today about lab testing for hormones.
Yeah. Well, listen, I just want to say that you were involved in this training that's going to be happening, I'm sure, because you're a leader over there in the educational team. So I'm sure that you really had something to say about the design and everything. And it's, like many things that you do, it's probably just absolutely useful and top notch. And any couple of words you want to say before we get into it?
It's about a year in the making.
Really? A year?
Yeah. We really wanted to distill down what has come from the, next iteration of the takeaways from the Women's Health Initiative, which, if anybody has been paying attention, is totally different than the initial takeaways from the Women's Health Initiative, when it came out, and all of the sort of fear around hormones. It's almost completely turned on its head now. And so we really felt it was important to dig into the research, and to really give an in-depth training on all the different types of deliveries that people are using for hormones now based on some of the new recommendations, knowing that hormone replacement therapy is going to be ramping up probably quite a bit in the next few years. And we want people to know how to do it safely, know how to monitor what they're looking for bone health, and so that everyone's really prepared.
Bravo you. Bravo you.
Yeah.
You know, as I was preparing for this conversation, and we're going to talk a little bit, we'll actually start with a little bit of the WHI, um, challenges and transformation that has happened, but it just made me reflect. We both went to National University of Natural Medicine in Oregon, and Tori Hudson was my professor, as was she yours as well when you were in
Yeah,
school?
she was. Yeah.
And she was doing HRT back when I was in school. I mean, she's such an extraordinary, a brilliant, bright light
Yeah.
in this space, and was able to really kind of think through in a pretty sophisticated way the
Did
findings
she
in
have you
WHI.
calculating the 80/20, the biased and triest? And, she
I
wanted all
don't,
of us to graduate ready to walk out the door and convert, a Premarin script to a bioidentical,
did she? Yes, that's awesome.
E3, E2 combo. Yeah.
She's such a great teacher. Anyway,
Yeah.
you know what? I definitely don't remember doing that, but it's been a while. It's been a minute for when I was in school. But I would like to. I want to invite her on the podcast.
Yeah.
I want to.
She'll knock your socks off. Yeah.
Yeah. And she has as my teacher, and yeah, for sure. Um, so let's talk a little bit. I think a lot of our listening audience is primarily clinicians, so they're probably aware of
Mhm.
the Women's Health Initiative and the fact that it's really been roundly challenged. But do you want to just give me a basic overview, like what are these findings that are turning the volume down on what? I mean, it's kind of extraordinary if you think about it. This just resulted in many, millions of women. I mean, uncalculable numbers of
Yeah.
women just being inadequately undertreated in the US and in the whole world because of the way the study was interpreted, was sensationalized, the study design, the use of synthetic,
Progestin.
non-bioidentical, yeah,
Yeah.
yeah, just the hormones actually used. Anyway, it's really extraordinary that we've come full circle on it. But go ahead and give me your thoughts and why you
Yeah.
think everything's going to transform here.
Well, I think, initially the takeaway was that, the Premarin, which is the conjugated equine estrogens that were mostly being used then, along with a progestin to protect the endometrium from that overstimulation from estrogens. That combination was associated with cardiovascular risk increase, breast cancer risk increase. They were arms of the study that they had to stop. And I think that there was a general sentiment that this actually isn't healthy for women, even if they have discomfort around the menopausal transition and there are benefits to bones. Discomfort, just stick it out, it's fine. But essentially, they sort of pinned some of these issues, really serious issues, on the estrogen side of the hormone replacement therapy incorrectly, right? It should have been more pointed towards the medroxyprogesterone acetate, progestin. It's a progesterone-like compound that protects the endometrium, similarly to progesterone, but in other parts of the body does not act like progesterone at all. It's in some parts of the body acts like an androgen, and it can increase our cardiovascular risk. And so for many, many, many years, the baby was sort of thrown out with the bathwater. And we thought of estrogen as increasing breast cancer risk incorrectly. And we thought of progesterone as increasing breast cancer risk, even in some cohorts. And so I think the going back through that research and sort of teasing it out and separating it has really, really changed the way we see estrogen replacement in our perimenopausal and postmenopausal women. And really finding that it doesn't increase breast cancer risk any more than a glass of wine in the evenings does. And I think those types of conversations help us to understand what the risk actually is so that we can make those decisions with our patients when they are sitting in front of us with a family history of osteoporosis and, hot flashes, night sweats, and sleep disturbances, and, staring down the gun barrel of maybe having to quit their job or, not being able to be there for their families.
Accelerated aging. Like
yes.
at every measure. I mean, that's really fundamentally what it is.
Exactly.
Accelerate all the chronic diseases of aging, the increased risk for developing them, all of them, really.
Yes.
As well as the aging phenomena itself. This is the motherload for us as women when we go through the hormonal transition and to have that completely halted. God,
yeah.
It's extraordinary. What's amazing to me too is that, when you actually tease the data out, even using these poor quality forms, of the estrogen and the progesterone, there is by and large no increased risk with them, except in these isolated subcohorts, the older women, long duration of use and so forth.
Yeah.
And I think the estrogen only, correct me if I'm wrong, the estrogen only group actually had a protective effect.
Exactly. They had a lower risk. So
right.
Yeah.
And this is with equine estrogens.
Yeah.
So now we know, as you were just talking about the calculations that Tori made you guys do. That's awesome.
Yeah.
That's so funny. But I mean, we've been using bioidentical hormones certainly in naturopathic medicine and in functional/integrative medicine more broadly in the longevity space. We've been using bioidentical hormones for many, 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 many years. What is the science? What are you able to extrapolate? What are the studies out there that really suggest bioidentical is the way to go?
Oh, I mean, there's a million women studied. There are actually some pretty big cohorts where they're using estradiol and progesterone and finding fantastic outcomes. And I think, nobody's really questioning that it's better to use as close to what the body makes as possible. And we do need more studies, and there are new drugs out, like the Bijuva with the oral estradiol and the oral progesterone, and everything's bioidentical. The patches are bioidentical. These are like big pharma, lots of money behind them. They're really well studied with big cohorts of folks. So, we look to some of those studies with the big money behind them. They can afford to really power them with lots and lots of women. And we can make those associations. And then we can be, a lot of us will be really detail oriented with our patients that don't tolerate those bigger doses of hormones maybe that they're using in the studies. And we have, lower doses compounded, very specialized and individualized formulas. And,
delivery systems.
I feel really confident about those. And there are even compounding pharmacies that have been they've been publishing for years and years, like observational studies based on their formulas in their patient base and looking at outcome studies. So I do think you can combine those types of studies and really feel confident moving forward with your patient base.
I'm so excited about this. I just want to plug the hormone replacement therapy course again. As really, you're going to drill into this. People are going to really get to train in depth. So all the testing and the amazing work you're doing over at Dutch, but beyond that, just this, where the rubber meets the road, how to prescribe, what to prescribe, how to start working with our sensitive patients, different routes of delivery, the whole kit and caboodle. That's awesome. Well, that's
exactly. Well, and there are more modules coming too. Yeah, it's a work in progress. I think the initial modules are exhaustive on the FDA approved stuff. And then we have more coming out, a module on compounded hormones, testosterone in women, which is, another area that's kind of a ravine in research, unfortunately, for
It sure
women,
is. Yeah.
plenty for men, but yeah.
Right. Right. Good. Well, thanks for stepping up to the plate. This is, again, you guys just go over to dutchtest.com to get details um, on this course. All right. Well, let's jump in. We were chatting offline for a while, and you have been in the laboratory space for many, many, many years now. Um, so you just have a good background on how to do it, on
Yeah.
what's reliable. And I guess you have two cool things. So you have the whole laboratory background, the whole um what we used to call when I was in the lab, the tile, the people in the tile versus those of us in education on the carpet. So
Totally. Yeah.
you have this strong um tile background, but then you also, as a provider, you've been using HRT in your clinic space.
Yeah.
And you have the advantage of looking at, as I read in your bio, thousands and thousands and thousands and thousands of cases and consulting with doctors the world over. So you've
Yeah.
got this exquisite vantage point, from which to, educate us. So, what are like, talk to us about hormones using, I mean, just like maybe differentiate between, using blood, the limitations of the blood, and then, moving beyond to, to
Other body
urine.
fluids. Why we even
Hmm.
think about other
Yeah, other body,
body
let's just say
fluids.
more
I know.
broadly, other body fluids. Yeah.
Totally. I think about serum being the gold standard because that's what we're using in all of our clinical studies as for clinical outcomes, I guess is what I'm saying. So, um, obviously we're using serum for baselines, but the problem with serum inherently is that serum is kind of a water soluble body fluid, and our hormones are lipids, lipophilic. And so they travel through the blood system in attached to hormone carriers, or called binding proteins. And estradiol and testosterone sort of famously bind to sex hormone binding globulin with high binding affinity. And that means that those hormones aren't going to get taken up by tissues, you know, uh, except under very special circumstances, possibly. But for the most part, free bioavailable fraction of our hormones is very, very low, like 1 to 5% maybe of all of what is made is going to be free and bioavailable. So there's your first limitation, right, with serum, is that you have to kind of guess. Well, this is your total level that you're producing, but we're guessing as to how much is getting taken up by the tissues and creating that experience of hormones that brought you into the office today. And that means for somebody who's coming in with acne, but their testosterone is normal, but what about their dihydrotestosterone? What about the way that they're metabolizing these things can have an influence on your presentation when you come in?
Is,
And
what's in the, I mean, this says something to those almost useless reference ranges as well, because
yeah,
they're just so ridiculously massive.
well, exactly. And they're overlapping a lot of times too. So, you have a postmenopausal range and a premenopausal luteal range, and you'll have some overlap. And if you're in the overlap, you're kind of wondering, like, well, what does that mean? Are you normal or are you a postmenopausal female? And even some of the female and male ranges will overlap, and it can be problematic with serum for a number of reasons. But I think from a functional medicine standpoint, we find it frustrating to have to do too much guessing when you're looking at a lab result. You want to be able to see what you're looking for, and serum can give you a little bit of like a 200-foot view, like a bird's eye view of what's going on, but often it'll be normal. And we end up with all the patients who we're told that they're totally normal, but they don't feel normal, and they're in to see us to figure out what's going on at a deeper level. So then we have to start thinking about other body fluids. How do we figure out what's bioavailable to tissues? Saliva got really popular in the 90s. There were books written, a lot of excitement around compounded hormones and hormone replacement therapy. And in saliva, hormone levels go up just exponentially when you're on transdermal hormones. And anyway, so they got really excited about saliva testing because you have only the bioavailable fraction in saliva, only free hormones. So nothing that was bound to a sex hormone binding globulin or albumin or cortisol binding globulin is going to end up in the saliva. So we're thinking, great, here we go. Now we've got some bioavailable hormones. We can see what the tissues are experiencing. But there's problems with saliva too, in that, saliva levels of these hormones are really, really low, like picogram per mil amounts low, really tiny amounts. And they suffered from some of the same limitations as serum, where you have the ranges overlapping, like a postmenopausal range and a luteal range will overlap quite a bit, by 25% sometimes, depending on the lab, or 50% sometimes. So it really kind of begs that question, like, well, is that helpful? Maybe not. And in the background, there's always been urine, but urine wasn't as convenient because you're having to catch every bit of your urine over the course of a 24-hour period of time in these big jugs, and do a science experiment and send an aliquot of your 24-hour jug urine to the lab for them to test it out. And people don't want to do it. So getting buy-in to do the urine testing was tricky. So right around 2013, 2014, Mark and some other big brains in the industry kind of started thinking about dried urine. Yeah. Well, Mark Newman is
Get away with going by.
Yeah. So Mark, and you'll find him published quite a bit in some of our bigger journals. He's gotten some articles into menopause and obviously some of the chemistry journals, but we're more and more getting into like BMC and menopause and some of the bigger clinical journals, because with the dried urine test, he's established serum correlations, which really propels urine in the eyes of a clinician, because you're able to look at a urinary level of estradiol and say, oh, okay, I know that I'm getting into, the clinical range that's protecting the bones, right? For instance. And I think this is kind of where lab testing is moving, just to try to find that perfect combination of things that gives you a deeper look for the people that we're trying to be preventive down the road, make sure we're getting into the right ranges, and also, provide the immediate support for hot flashes, night sweats, and lower urinary tract symptoms that often improve, interestingly, as a placebo effect with hormone replacement therapy, which is kind of another thing.
How has that been discerned?
Well, they have done clinical trials where they gave people estrogen or placebo, and we're looking for hot flash frequency and severity and finding improvements even with placebo. So I think, even if you pay attention to somebody's symptoms and, give them the impression that they're going to get some help, they often improve. So it's kind of interesting. So we do have to look at other deeper clinical markers. I mean, your bones probably aren't going to increase in bone mineral density, and, as a placebo effect, probably not.
Listen, I want to just ask you a question because I don't want to forget it. And you kind of threw out a little teaser.
A nugget.
Yeah. And that is where laboratory science is heading, providing reference ranges for targets. Like, what do you see? So this is where you need to be if you're looking at bone density. This is where you need to be if you're looking at brain health and dementia prevention and cardiovascular disease benefit, etc. Skin.
Well,
go ahead.
That's exactly, I think, where we are headed. We're starting by publishing or at least starting the conversation around osteoporosis and bone mineral density, because it's a really easy like stake in the sand. There have been quite a few studies that gathered together all of the laboratory evidence, serum laboratory evidence around estradiol levels and bone mineral density, and sort of you can extrapolate from that kind of where somebody should be based on, a study from the 90s was looking at premenopausal women and found that if their estradiol in serum was 60, then that meant that their bones were healthier than those who had bone mineral or had estradiol levels under 60. So 60 was kind of like the cutoff. But the methods have gotten a lot more sensitive since then. Now we're sort of using liquid chromatography, mass spec methods. They're much more sensitive. And actually, you don't have to have estrogen levels at 60, really, necessarily. It may be more like 40 or even 20, depending on the method. So, there may be a wheelhouse where people can live on their hormone replacement therapy that keeps them in that 20 to 60 is really where we tell people that they should probably be. And maybe towards the higher end of that range if you're going into menopause and you're younger, maybe you've had a hysterectomy and you don't have your ovaries anymore and you're 30, you should probably have estrogen levels that are a bit higher in that, towards the 60 versus a 20. But if you're 65 or 70, maybe it's okay to be 25 or 30 in serum for a total estradiol. Anyway, I think, if we can be that precise with people, that could make a huge difference. You think about what people end up struggling with end of life, or the thing that takes away somebody's mobility and puts them in the hospital and puts them on a trajectory towards like end of life. It's the hip fracture or the,
Yeah. It's huge.
Yeah.
Right. I like that. But you're moving beyond, you're starting with bone, putting your stake in the ground there with bone, and then you'll move on and look at other
Exactly.
associated issues. Because it's not, I appreciate the placebo comment. I have seen something that appears like that in practice where hormones are imbalanced and there's huge symptoms associated with it. And just the awareness of that imbalance can cause a considerable drop, even though
Yes.
it's going to take, this is with elevated hormones, even though it's going to take a little while for those to drop. I've seen on more than one occasion, just the knowledge of, oh, okay, I'm elevated. It's almost like, oh, okay, that's what those symptoms were.
Yeah,
I'm
that's
not
not
crazy. I'm
nothing.
not this. Yeah,
Yeah.
okay. So I can almost just let it go. I've seen that with multiple times. It's really fascinating.
Yeah.
But those symptoms were absolutely real
Totally.
while they
Oh,
were before they were there, before there was a conscious awareness around why they were happening, because there was a hormone imbalance. Anyway, so
absolutely
as
right.
you peg reference ranges, just really across the board for these imbalances that we see in our patients all the time, that's going to be awesome.
Yeah. Yeah. We just don't want to be underdosing people, just because
Right.
their hot flashes went away, but their poor little bones aren't getting what they need.
Right, right,
Yeah.
right. And thinking about all of the other myriad benefits, like across the board, the system-wide
Yeah.
benefit of
Yes.
sufficient hormones. Yeah, it's incredibly important. The other piece about the WHI getting turned over was this idea that, we can't start women on hormones postmenopausal, and that it's not safe. And,
Right.
that's another kind of welcome change to the conversation, and empowering change to the conversation. I'm seeing, Sarah Gottfried, of course, you know who she
Yeah.
is, kind of a big influencer in
Definitely.
this space, talking about menopause 3.0, she's terming it, but it's like, there's a revolution happening, I think, in women's health, the seed is this. The seed is the WHI, and just really kicking it to the curb. Like I think it's very empowering. And a
Yeah.
lot of us, in this space are changing our, just, just have an eye towards adequately supporting women in women's health
People are
issues.
still asking though, like, is it too late for me to put
Yeah.
this person on estrogen? And even though they have all the symptoms in the book of low estrogen and they, have bone loss and cardiovascular issues. And I don't know, you have to be willing and ready to individualize your approach, I think.
Yeah.
And it gives us permission to do that now, which I think is really exciting. And I always
It
remind
is.
people of that.
And
Yeah.
now people need to learn how to do it if they
Yeah.
don't, and
Yes.
you will help them in that arena.
We're ready to
Um,
help. Yeah.
so you mentioned something about, it was funny, you first talked about collecting that 24-hour
Yeah.
urine, which I've done. I can hold my
Oh,
jug
sure.
up.
Me too.
Of
Yeah.
course you have.
Yeah.
Yeah, what a pain, just being at the lab, a laboratory myself where we did 24-hour urine measurements of various things,
Yep.
and we and the lab team would all have to test a new assay, and there'd just be urine jugs all over the
Oh,
place.
yeah. All the orange jugs. Yep.
Yeah. Um, so you mentioned that Dutch. So for anybody not using the Dutch test, it's this dried urine specimen. It's sort of the revolution, the aha moment for Mark Newman, the founder of Precision Analytical. Um, talk to me about what it is and why
Yeah.
it's way better than a giant orange jug.
Yes. Well, the easy explanation is that there are 4 or 5 collections over the course of the day. So usually we have people start at dinner time. So before dinner, before bed, you'll just pee on a strip. You can just stick it in the flow, or you can pee in a vessel and dip it. Either way is totally fine. And then you dry it. It's dried urine, not a wet urine sample. So we don't want the urine sample to stay wet when it's in transit in a closed baggie, because wet urine samples have hormones that degrade a lot faster. And so it can cause weird results to happen. So we always have people dry them really, really well. So before dinner, before bed, if you wake up in the middle of the night, you pee on that strip too. If you pee a lot in the middle of the night, we usually have people collect all that urine in a vessel and dip it in the morning. And then, and then as soon as you wake up in the morning, you want to catch that first morning void, which is a really great way to look at cortisol levels during the night while you were asleep, and melatonin levels while you were asleep, are all going to be evident in that first morning void. And then the last sample is the 2 hours later, or your next urine that happens after your initial waking void. So there are really, it's pretty simple procedure. Dry all those samples, send them in, and then we use creatinine levels to kind of normalize for the dilution or concentration of the samples. And we also use a complex calculation that even includes height, weight, sex, all kinds of age of the patient, that really hones even more the accuracy of the resulting. And that's how we generate our idea of what's going on. And that really constitutes about 18 hours of the day. So it's not a full 24-hour look, but it correlates very nicely with a 24-hour urine. We have published article on that, sort of validating that concept and the strong correlation between the analytes and the 24-hour urine samples. And we also have correlations between our Dutch urine 4-spot and serum. So I think between those two things, we feel pretty confident that, there are certain circumstances where urine is a little tricky or not very helpful at all. And one is, with urinary hormones, you're looking at glucuronidated conjugated hormones. So people who have, say, there's a fairly common, when I say common, it's probably like 5 or 10% of the population at large. But if you have a large Asian or Southeast Asian population, it can be much higher, 80% in some populations, have this gene deletion that is called UGT2B17, and it causes you to not glucuronidate your testosterone, which means in urine you have almost zero for testosterone, but it's not really real. In circulation, you'll find that testosterone probably healthy and normal, but you just don't pee your testosterone. And that person will never pee their testosterone. So you would want to mark in the chart, I think this person has a UGT deletion. And we always try to identify that and comment that really clearly on the reports when we see that, because it is probably the biggest issue that urine has with not correlating with serum would be in that one area.
Okay.
Yeah.
And we've encountered that.
Yeah.
We've discussed that issue in our clinical rounds when we saw it.
Yeah. If you test with urine, you're going to run into it. I'd be surprised if you didn't.
Yeah.
But if you just kind of dabble in urinary testing of hormones, you may never see it. It's not super, super common, but yeah, don't be surprised if you do.
So obviously in that case, testosterone, we just want to do it in serum. Are there any other
Yes.
any other times we might be leaning in on serum
Well,
instead of urine?
I would say, if you have a patient population that has like renal disease, kidney failure, any reason why what somebody's putting out of their body is not going to correlate with what they're keeping in circulation.
Right.
You know what I mean? That should go without saying maybe, but sometimes we really want to stretch it because the patient can't conjure up enough saliva for a saliva test, or they are scared of needles. And you really want to use urine, but they're in kidney failure. Don't do it, because
Don't.
no,
Yeah.
it would give you the wrong impression maybe of some of the hormone levels. And then children, it's another area. Their creatinine clearance is different, and we, Dutch at least doesn't have validated ranges for kids. So, yeah.
Kind of an exploratory, but we all knew, mom and
Yeah.
dad, as we were going into it, that we weren't sure of the utility of it. It did end up helping, provided
Yeah.
some insight and some guidance, but we used it, just really as an exploratory. So on this topic, the creatinine is muscle turnover, and
Yeah.
if somebody has just a really low BMI or just poor muscle mass, would that
Mhm.
potentially skew the concentration? And would you reject the specimen in that case? In which case
Yeah.
they need blood? Is that something that
Yeah.
you
If
encounter?
creatinine is too
Or
low. Yeah.
they could just really restrict fluid for that day,
Yep.
right?
That's true. So sometimes we can work around that. And yes, so as long as we can get our creatinine levels above the cutoffs, we can test the sample. And there are even creative ways we can, if we're missing a bedtime sample or an evening sample because it's too dilute, or the creatinine's too low, even if we throw that one sample out and we have the other three, we've done all kinds of internal studies that show that, that doesn't really change the final results very much, because we're sort of pulling and averaging, and so you wouldn't get a free cortisol for that one time point, but the rest of the analytes would still give you, even if you didn't have 18 hours of data, you had 14 hours of data. It doesn't change all that much. However, if it's a first morning void, we would reject the whole thing, because that carries a large amount of hormone production, and so does the second morning void. So if it's either one of those two, probably have the patient recollect or talk to the provider to figure out if there's a likelihood we're going to get a better sample or maybe not.
You can just brainstorm if you confront these. And I have to say, just if
Yeah.
anybody's curious, it's the exception. Maybe we've needed to do recollection in my practice, a couple times over the many, many years. I mean, mostly it's completely solid and reliable.
Yeah.
All right, so we'll put a sample report on the show notes. Anything else we're dialoguing about here, a link to their hormone training, we'll put on the show notes. But we're going to talk about the test and what's on it. We'll talk about some of the analytes, why this is embraced by our world, some of the benefits of seeing, some of these analytes that aren't available in our standard laboratories that we're using. But
Right.
anyway, pause this, go grab the sample report, and you can look at some of these with us. Why don't you talk about just the report overall and what we're getting, and then, some of those really cool metabolites that guide us in our treatment.
Totally. Where urine really shines, I think, is it gives you an idea of the tissue experience of a given hormone. You can look at estradiol, progesterone, testosterone in other body fluids, but you don't always get the full picture of like how it's breaking down. Some of those breakdown products actually carry secondary actions at the tissue level that do something different. Like progesterone is a really, really good example, right? It breaks down through 5-alpha reductase into allopregnanolone, and the 5-alpha metabolites bind GABA receptors in the brain and make us feel relaxed and help us sleep and give us our idea of stress resilience. Comes from progesterone metabolites, not progesterone itself. And I think that really underscores the importance of kind of looking at these things. And estrogen is another example. Estradiol, yes, it binds its receptor. It has its actions at the tissue level that tend to be proliferative and predictable. But as it breaks down to become more water soluble so that it can leave the body, it becomes other things that still act like estrogens at the tissue level, still can bind estrogen receptors, and some of them, like 16-hydroxyestrone, which is probably the most famous one, and it can be high in all kinds of things like lupus and rheumatoid arthritis, and it is higher in those with higher risk of breast and endometrial cancer, breast cancer in particular, but prostate cancer in men. And so we like to have eyes on that one because it binds estrogen receptors kind of weakly, weak affinity, but once it's on there, it binds covalently and it never falls off until that receptor degrades. So its action on the DNA and that proliferative activity in the tissue is really intense with 16-hydroxy, even though it's technically a weaker estrogen. So all kinds of interesting things you want to have eyes on when you're looking at a urinary readout on hormones. You're looking at so much more than just how much hormone was produced and it is in circulation to target tissues. You're kind of looking at what's taken up, how it's breaking down, how it's interacting with those tissues on its way out. And, that's really what a hormone feels like in the body and why somebody's in your office.
So, prescribing estrogen, obviously it's a no-brainer, or some, a premenopausal woman, it's a no-brainer to want to look at those metabolites. I think I think that it's well established in our community, and it's very empowering because we can change the fate of how we're metabolizing. We can get in there and manipulate it. I was
even with food. Yeah.
Yeah, right. That's right. Just thinking about, you brought men in the Prostate Cancer Association, and it just made me think of seeing, so somebody, a man or woman, but we could definitely see it in our testosterone replacement men, converting some of it over to estrone and then down to the 16.
Yeah.
And so you'd want to be tracking these estrogen metabolites really in anybody who's on
definitely
hormone replacement therapy. So even testosterone alone, where some clinicians might not be thinking about the estrogen metabolites, we need to be thinking about the estrogen metabolites.
I sure think so. And I think, one of the things that's changed in the last 10 years, I would say, in men's health is that, we used to think about using aromatase inhibitors with testosterone replacement for most men, especially over the age of 50. Now, we're not using as much aromatase inhibitor in those guys because there have been a lot of studies actually that sort of show that erectile function suffers when there's no estrogen around, and bone mineral density and all these other sort of things that we weren't really thinking about when we were trying to preserve all the testosterone at the tissue. So we do want more testosterone running into estrogen, but we do need to direct traffic down to the anti-proliferative metabolites that are supporting, supporting those tissues and not hurting them on the way out.
It's great. super useful for so many reasons. So yeah, shutting down with a drug effect will often have some fallout, some secondary
Totally.
fallout that's not picked up immediately. I'm pretty curious about what's in store for GLP-1 actually with that idea in
Me
mind.
too.
Yeah, yeah.
Yep.
A different conversation. Um, so there's other estrogen metabolites. So why don't you touch on those? Because there's some that we really want.
Yeah,
Go ahead.
yeah, exactly. So the way phase one metabolism works is, estradiol and estrone go through the first step of hydroxylation, and there are three different cytochrome enzymes that sort of catch those estrogens and add a hydroxyl group to one of the carbons. And which enzyme is going to decide which carbon that hydroxyl group is attached to. And it's amazing to me how much which carbon that hydroxyl group gets attached to influences the stability of that metabolite and totally changes its action at the tissue level. So just like one little change. And so we have a 2 hydroxy, a 4 hydroxy, and a 16 hydroxy. And the 16 hydroxys are bad because they influence our breast and prostate cancer risk. The 4 hydroxys are bad because they're very unstable and they can damage the DNA and endometrial cancer and some of the more fibroids and growth proliferation in the uterus are associated with those 4s in particular. And it's a cytochrome system that's upregulated by inflammation, which is epidemic, it seems like, So there are really some great ways that we have in our arsenal to downregulate some of those metabolites just by treating what we are finding, is drawing people into the office. So anti-inflammatory supports, and because we want the 2 hydroxy estrogens. So that kind of leaves us with the 2 hydroxy E1 and E2, which, themselves, because they lead to the methylated 2 hydroxy, converts into 2 methoxy E1 and E2, and those act as anti-proliferative, anti-tumor. They're shrinking tumors. And there are even compounded 2-methoxy estradiol formulas that people are starting to prescribe to patients as a way to leverage some of that anti-proliferation at the tissue level too. So it's kind of interesting, kind of where we're sort of moving with. Yeah.
Men and women.
Mm-hmm.
Men and women both stand
Yes.
to benefit from having sufficient
That's right.
methylated 2s.
Yes.
Well, clarify this for me. I remember reading quite a while ago that 16 may be beneficial in postmenopausal women with otherwise very low estrogen. So it might
Yeah.
help with bone density,
Totally.
and help
Because it's such a
offset
strong
some.
estrogen. Yeah.
So do you think about it a little bit more nuanced? I mean, you also associated it with some hormone sensitive cancers as well. Like, so how do you think about it in the
How do
postmenopausal
you
woman?
juggle it
Like,
a little bit?
yeah,
Mhm.
yeah. I mean, I guess we might be, if somebody's on HRT, then you don't really need to keep any 16 around. You can just metabolize
You
it
can
because
move
they've got estrogen.
through. Yeah. But if you're a postmenopausal female, you're not a candidate for hormone replacement therapy for any reason, and your 16 hydroxy is dominant, maybe that's helping you,
Yeah.
In fact, if your vitamin D levels are too low, it can cause your 16 hydroxy estrogens to also be low because D is a natural inducer of the enzyme that leads to 16 hydroxy formation. So like there's kind of this link in other ways too between low 16 hydroxy and low bone mineral density.
All this
Yeah.
balance.
So it's kind of both. Yeah, it's kind of a two for the 16 hydroxy, especially when your estradiol is in the postmenopausal range. If your 16 hydroxy is also low, it's kind of a 1-2 punch for.
Right.
Mhm.
Feeling pretty lousy.
Yeah.
But in other
Yep.
cases, if you see some background 16, would you advise that clinician perhaps not to lower it? Because
Yeah.
we may want to pull the trigger and lower it just reflexively because we know 16 is associated with cancers, but in certain cases, you're going to be more nuanced.
Yeah. Well, you'd weigh it out with the,
Yeah.
patient's family history. What are their mammograms look like. I mean, you might be able to say, hey, let's actually beef up your 16 a little bit because maybe it's a little bit too low and you're postmenopausal and you're not a candidate for E2 for whatever reason. Let's get you on the D and bone supports, like double down there. There isn't a lot of research on increasing 16-hydroxy in particular as a way to protect the bones. So I don't necessarily think that that's the right approach, although there are some of the supplements out there for bone support that has, I don't know if you've noticed this, but that has St. John's wort in there, which is an inducer of 16-hydroxy formation. So I think, there's some out there that are trying that direction.
Right.
Yeah.
No, I didn't notice that. I don't think I'm not using any that have St. John's wort in it. That was fascinating. Wow.
Yeah.
Wow. Biochemists out there in our space.
Totally. Like, what's this going to do? It can only help.
The progesterone metabolites are incredibly important, just making sure people are able to produce, some of the juicy, they're beta driven, right? Or are they alpha driven?
They're alpha driven. Yeah. Usually 5-alpha reductase is problematic, right? Because it makes the androgens stronger and it gives us acne and it makes our hair fall out and stuff like that. So usually we're not thinking about increasing 5-alpha reductase activity across the board. But it is one thing that we want when we give somebody progesterone, usually as they're in the perimenopausal transition or in menopause. Yeah, we want to protect the endometrium if we're giving HRT always. But we want to help them sleep a lot of times. It's such a common complaint. And
it's a potent anxiolytic. It's incredible.
It really is.
Yeah. And it's, it's brain protective and nourishing. I think in that same capacity.
Yeah.
All right. So let's talk a little bit about the testosterone metabolites, and then we can move on to the to cortisol. I mean, the cortisol awakening response. You guys added it first. I don't even know. I think it is elsewhere perhaps now, but yeah. Let's tour the test.
Do androgens? Yeah.
Yeah. Let's
it.
touch on androgens, and then let's move over to cortisol.
Yeah, I would say, androgens are probably one of the top reasons people will order a Dutch test. They want to understand the tissue experience of testosterone and DHEA. So they're interested in looking at dihydrotestosterone, but really even a longer term marker of DHT formation in the tissues is 5-alpha androstenediol. So it's like the next one down metabolically. So you can have a normal DHT, but have an elevated 5-alpha andro, and that should tip us off that this person has an awful lot of DHT forming in the tissues. And it's not necessarily testing what's going on in the hair follicle or the skin, but you can get a pretty good idea of total body, what's happening with total, testosterone utilization. And if you have a strong 5-alpha preference, even if your level of testosterone is normal in the serum, and the testosterone is normal in the urine, if the 5-alpha is high or dominant, that really drives that person's symptom experience when they are coming across their testosterone at the tissue level. And
I've seen what you're describing. Yeah, go ahead.
Yeah, well, and it helps you to understand what therapeutics are going to be high yield. So if you have somebody with hair loss and you do a Dutch test, and their testosterone is normal and they have a 5-beta preference, that if you put them on saw palmetto, it's probably not going to do anything. So you're not going to do that. You're going to look at other parts of the test and see, they're low in biotin, or they're low methylator, or their
cortisol patterns.
Or cortisol patterns high, or, there are other things that are going to take center stage, and you're going to skip the 5-alpha blockers, So I think that's really where the Dutch is helpful for androgens.
Yeah. And in PCOS, I mean, this is a whole
ball of wax.
We've talked about it on this podcast. We've had really good, juicy discussions on it. And we'll link them in the show notes. So all my previous podcasts with Dutch, in fact, any any content that we have available, we'll just put it on the show note and maybe label, because
Yeah.
it's just exquisitely useful. Teasing out what's happening in progesterone or excuse me, teasing out what's happening in PCOS and offering some really clear guidance
Yeah.
on treatment based on laboratory data.
Yeah, we have
Um,
so many case studies that are, different types of PCOS, where some of
yes,
them will be really, really low estrogen, but super high
yes,
testosterone and epitestosterone, that's just coming straight from the ovaries, versus the high DHEA type, and it's
yes.
really easy to see the way it's laid out on a Dutch test.
It is. It is. And we already have a discussion in place where we moved through a lot of those kind of phenotypic presentations.
Yeah,
Yeah, it's so
cool stuff.
useful. All right, what else do we have? Let's talk about cortisol a little bit and
Yeah.
that amazing cortisol awakening response.
Yeah, this is where saliva really, really shines, I think, is in the
Good.
cortisol space.
Actually, I was going
Um,
to ask you that, like when we might use saliva, if
yeah,
saliva is a viable specimen.
sure. And saliva, I think, is the way we do it is really easy, where you kind of put the little salivette device in your mouth and you just kind of let it fill up with saliva. You kind of chew on it a little bit and you can tell when it's full. And it usually takes me about 6 seconds to get that thing full and spit it back into the tube, and you get that real time assessment of free cortisol levels. Um, and I say that because there are so many different salivary testing labs that do it differently. Like, you might, drool into a big tube, or you might, you know, um, but the idea is that you're kind of doing this passive drooling. You're not like hawking spit necessarily. You want the flow rate to be like natural, for those collections. But with those collections, it can be hard to get the precise data for a cortisol awakening response, for instance. So that's why we have to use the salivette devices. But they're super easy. And with the cortisol awakening response, you're really doing several sample collections over the course of an hour. So you wake up, you spit in the tube, basically, and then a half an hour later, you do it again, and a half an hour later, you do it again. So it is a little bit front loaded. But when you do it that way, you're able to get a sense of the HPA axis, the hypothalamus, pituitary, and the adrenal starting to talk to each other right when you open your eyes and come into consciousness for the day. There's this relay that happens that involves the hippocampus of the brain. And it's almost like it's downloading whatever you did overnight into your adrenal function and informing your adrenals how to come online, like turning on the photocopier in the morning at work. So you don't have to do it when you're trying to make a copy later in the day. It's like gets everything ready. So your adrenal function sort of skyrockets upwards, and it's very predictable. On a Dutch test, it's 50 to 160% rise you want to see in the first 30 minutes of waking. And then you want to see it come back down. You want to see it return. It should look like a triangle, on the lab result. And any abnormalities there can speak to the health of the hippocampus and the HPA axis. And with chronic stress, you might not see a rise at all. Chronic, like PTSD, or, people with, chronic diseases, chronic pain, tend to have no awakening response, or even kind of a negative one where they're just moving downwards. And then others, like depression, you might see a really exaggerated one, or anxiety, you might see a prolonged awakening response. People have, yes, anticipatory stress.
Right, like
Yeah.
Monday mornings,
Mm-hmm.
this job I'm about to go to.
Yes.
Yeah.
And some people, we wonder, like, maybe stressed about collecting their samples.
It is really easy. I want to just say something because you touched on samples, and being consistent with collection. We've known for a long time that using saliva to measure cortisol is extremely helpful, but there was a very critical paper written because of the varied collection techniques.
Mm-hmm.
And I appreciate you bringing that forward. And the inconsistent collection devices, the changing collection techniques. But I think there's something incredibly important about just passively saturating the cotton. You're
Yep.
not stressing out with the effort of spitting in a tube and your mouth
Yeah.
is dry or whatever. And just really using that same type of collection for the full measurement, and repeat it like that's the method that you guys use. This particular paper, it just struck me because we know there's value in the
Yeah.
cortisol awakening response and the 4-point salivary cortisol, extremely useful. They're not invasive specimen, could be very important if we got it together with regard to consistent,
Collection.
appropriate collection. Yeah.
Totally. And a lot of those papers a lot of that research that was done that showed the utility and the application of cortisol awakening response in clinical, those are all laboratory, studies where everything was collected so specifically, and we're not following people home and making sure they do it right. So we try to set them up for success by giving them kind of some equipment to use, and it makes it really reproducible. So, yeah.
It's important. I think it's important to continue to see research coming out using salivary cortisol.
Agreed.
Because I know people sometimes rely, or scientists will want to rely on blood cortisol, which is just crazy if you think about it. Going for the stick, the experience of the stick. But anyway,
that's right. Well, I think the other thing that Dutch does right is we also test cortisone at all the same time points. So free cortisol and free cortisone, which I think, is the bane of some people's existence, because they're like, it's so hard. What do I do? What do I do if one's high and one's low? And it does force you to think an extra step sometimes in patients who are on certain medications. But I remember working at another lab that didn't do the free cortisone. They just did the free cortisol like everyone did, in the early 2000s. And this provider I was talking to on the phone, he had put the patient onto lisinopril, and he was a very good historian. So he had all of the labs from before the patient was on lisinopril, and he put her on the lisinopril, and then they retested, and the free cortisol was flatlined. And he was like, "Does lisinopril lower cortisol production?" And I said, I don't know. So I got on PubMed and I was searching around, and there was one paper that said that lisinopril lowers free cortisol. So I called him back and I said, yeah, it does. It lowers cortisol. And the takeaway was that there was some sort of HPA axis dysfunction, but that was incorrect. And I found out from being involved in looking at so many tests of patients who are using lisinopril and other ARBs like losartan, ACE inhibitors and ARBs act similarly. Even spironolactone in the right dose actually increases cortisol clearance into cortisone. So it doesn't lower your cortisol production. It just increases 11-beta-HSD2 enzyme activity in the salivary gland and the kidney, so that your saliva is going to have cortisone in it and not cortisol, because that local conversion is happening right there. So that was a big aha moment for me, that gosh, the metabolites really matter, because sometimes that's not an actionable thing. That's what that medication is supposed to do. And that's part of how it keeps your blood pressure normal. Yeah. So anyway.
The opportunity of learning a lot, because you do look at labs that we don't see in real life that often.
Right? I know. And then sometimes when you're talking to somebody on the phone doing a clinical consult, and they'll say something like, oh, but I know lisinopril lowers cortisol. You can say, well, it doesn't really lower cortisol.
Yeah, you really want to make that distinction.
Yeah, totally.
It's incredibly important. It would not be a drug if it dropped cortisol. No. So we have covered a lot. I absolutely love your wealth of knowledge. It's so fun. I could pick your brain all day, Allison, on the cases that you've seen, on all these pearls that you've learned, on other variables that are going to just influence the enzymatic activity and shift metabolism. One of the nice things about the report is that you capture all of that. That
Yeah.
should be a publication. So you capture all of it. It's available to us so we can do our drill down ourselves on, why we're seeing these results that at a glance look a little bit crazy. So instead, don't panic, read through
Yeah.
the report,
Yeah. We
reach
try to
out
make
to the
notes.
team. Yeah.
Yeah.
But it would be an interesting publication because you look at way more natural interventions and you're actually tracking them.
We do.
So
We do, and we publish on this stuff. That's one thing that I really like about being a part of this lab is that we have a robust research team,
yeah,
and
you have a commitment.
we really spend a lot of money
Yeah.
researching and publishing our findings because it's important. We've published on DIM and how it affects estrogen metabolism. We have all kinds of interesting tidbits out there on PubMed. A lot of it's open access. Actually, all of it is open access. So you can read the studies in their entirety, and it's fascinating. So, and we're not done. We're still going.
No, you're not.
Yeah.
Whenever I see Mark, he's talking to me about what you're up to.
Yeah.
Okay. So we will corral together your publications. In fact, maybe you can just we'll reach out to you, and so we can pull together kind of
I'll
a
drop you the
curated
link.
suite of
Mhm.
publications, and then we'll pop those on our show notes as well.
That'll be great.
Dr. Smith, thank you for coming and joining me today, and I'm so glad we had a chance to connect. This was a really fun conversation.
Me too. I loved it. Thanks for having me.